Hello, and welcome to the 2022 APACS Health Summit. I'm Madeline Milka, President and CEO of APACS, the Asian Pacific American Institute for Congressional Studies. Throughout the year, APACS is committed to engaging in conversations about policy issues affecting the Asian American, Native Hawaiian, Pacific Islander community. Our summit series this year begins with a critical topic, healthcare. Today, we've gathered experts from across the industry to talk about a wide range of topics. We cover issues such as mental health, innovation, health equity, and cancer from top AANHPI leaders in the field, from academia, industry, and advocacy. Before we begin, it's my honor to introduce Health and Human Services Secretary Javier Becerra for remarks. Secretary Becerra is the 25th HHS Secretary and the first of Latino descent to hold the position. During his long career, Secretary Becerra has long been an advocate for affordable health care as California's Attorney General and a member of the United States House of Representatives. Please join me in welcoming Secretary Becerra.
President and CEO Madeline Milka, thank you for that introduction and for your leadership in promoting Asian American, Native Hawaiian, and Pacific Islander participation and representation at every level of the political process. I also want to thank the Asian Pacific American Institute for Congressional Studies for holding this important summit and for more than 25 years of outstanding work. It's been a great partnership with you over the years. In the 2021 election cycle, more than 150 Asian American, Native Hawaiian, and Pacific Islanders ran for office. And today, Asian Americans, Native Hawaiians, and Pacific Islanders are leaders in so many areas across the Biden-Harris administration and the nation. That, my friends, is a true testament to your work. Because we know representation matters, our leaders should reflect that diversity of all of our communities that they serve. And I'm committed to that principle as Secretary of HHS. 2 weeks ago, as the co-chair of the President's Advisory Commission on Asian Americans, Native Hawaiians, and Pacific Islanders, I had the honor of swearing in 23 outstanding Americans as commissioners of that auspicious body. And as Secretary of HHS, I'm proud to have the White House's initiative on Asian Americans, Native Hawaiians, and Pacific Islanders call HHS home. The initiative's mission is to drive an ambitious, whole-of-government agenda to advance equity, justice, and opportunity for AA and NHPI communities. So it's both a pleasure and a privilege to join you here today to continue our work on behalf of the AA and NHPI communities. We're at an inflection point in our country's history. For too long, systemic barriers to equity, justice, and opportunity have put the American dream out of reach for many AA and NHPI communities. And racism and xenophobia against AA and NHPI communities continue to threaten the safety and dignity of countless families. But now we have a choice. We can choose to build back a better country where we prioritize equity and justice, or we can choose to continue with the status quo, where inequities exist throughout our society, including in health. In the Biden-Harris administration, we've chosen progress. We've chosen to build back better. Over the past year, we've worked to expand health equity in AA and NHPI communities by ensuring people have access to COVID-19 vaccines and therapeutics, to testing and masking, and to quality health care. Today, more than 211 million Americans, including millions in the AA and NHPI communities, have received 2 doses of the mRNA COVID-19 vaccine or 1 dose of the 1-dose COVID-19 vaccine. This didn't happen by accident or chance. This happened through hard work. It happened through strategic investments, tireless outreach, culturally competent messaging, and strong partnerships with folks like you. We have routinely engaged AA and NHPI communities in our vaccine confidence work. For example, the Slow the Spread and the Building Vaccine Confidence campaigns were launched in 14 AA and NHPI languages. HHS has also produced TV ads in English targeting NHPI audiences, Cantonese Chinese, Mandarin Chinese, Hindi, Japanese, Korean, Tagalog, and Vietnamese. Through the American Rescue Plan, we've lowered or eliminated health insurance premiums for millions of lower and middle income families enrolled in health insurance marketplaces, including 197,000 uninsured AA and NHPI individuals. Now, 14.5 million Americans have quality, affordable coverage through the marketplaces. In addition, we have also decided to shoot for the moon setting a new goal to reduce the death rate from cancer by 50% over the next 25 years. And we're working to improve the experience of patients and families living with and surviving cancer. The Cancer Moonshot is a beacon of hope to Asian and Pacific Islander men who are twice as likely to die from stomach cancer as compared to non-Hispanic white men, and to Asian and Pacific Islander women who are 2.5 times as likely to die from the same disease as compared to non-Hispanic white women. Finally, we've invested billions of dollars to expand the healthcare workforce and improve workforce diversity. And we've prioritized behavioral health of children, youth, and their families, with an emphasis on improving access to care, promoting equity, and fostering innovation. All of this work is topped off by our effort to combat hate in any and every form, wherever it rears its ugly head. A few months ago, along with U.S. Attorney General Garland, I took part in a listening session with stakeholders on the bipartisan COVID-19 Hate Crimes Act, which was signed into law by President Biden in May 2021. This bipartisan piece of legislation makes significant improvements to our nation's response to hate crimes, because we know personal safety is vital to our public health, and hate has no place in our society. In all of our work, one thing is clear. The needs of our AA and NHPI communities are wide-ranging, unique, and urgent. And we will need your help to ensure we're responding to all of them with the attention they deserve. So my ask of you is simple. Be our partners. Continue to help us turn the dials of progress. Help us get it right. Because together, there's nothing we can't achieve. Together, we can fight anti-Asian bias. Together, we can promote health equity. And together, we can ensure AA and NHPI families not only recover from these crises of today, but build back better. President Milke and the AAPACS team, thank you again for inviting me to address you today. I look forward to working together, as we always have, to build on your quarter century of progress. Thank you.
Thank you for your leadership, Secretary Becerra. Next, it's my honor to welcome Representative Barbara Lee, co-chair of the Health Task Force at the Congressional Asian Pacific American Caucus, or CAPAC. She represents California's 13th Congressional District. As a former psychiatric social worker, Representative Lee has spent her career advocating for affordable health care, combating the HIV/AIDS epidemic, and fighting for reproductive justice. Join me in welcoming Representative Barbara Lee.
To highlight the health disparities in our fight against COVID-19. For many years, AAPACS has been an inspirational force in leading the fight to equalize representation for the AAPI community. And I'm so honored to be here with you today and to be joined by my good friend, Representative Ami Bera, our fellow co-chair of the Congressional Asian Pacific American Caucus's Health Task Force. Now, improving access to quality, affordable health care, it has always been a priority of mine. The racial disparities in this country's healthcare system are staggering, and they're unacceptable. This was true long before COVID hit, but speaking to you now in the third year of this pandemic, we know that these inequities are far more pervasive and damaging than we feared. We know that Asian American and Pacific Islanders have been among the most impacted by the pandemic, facing far greater barriers to testing and treatment, and being subjected to an onslaught of despicable, racially motivated hate crimes that create lasting trauma in communities. It is saddening to know the reports indicate Asian Americans experience greater stress from this racism than from the threat of COVID itself. Now, as a Black woman in Congress, I am all too familiar with the stress that such attacks can cause, even if they aren't directed at you personally. What we need now is legislation that works to eliminate health disparities in minority communities. The Health Equity and Accountability Act is crucial in this fight. We need to expand access to care, including mental health care, for the underinsured and uninsured. We need culturally competent, linguistically appropriate care. We need to disaggregate the data on the Omicron variant so that we can get a clear picture of how our communities are being affected. And we must refuse to tolerate acts of hatred against the AAPI communities and ensure mental health is not left out of the equation. Thankfully, we finally have a partner in the Biden administration who is working very hard to prioritize racial equity. I am looking forward to working with organizations like yours and my amazing colleagues, including our phenomenal chair, Congresswoman Judy Chu and Grace Ming in KPAC, led by these phenomenal women who are doing a phenomenal job. Also, the CBC, the CHC, and the Native American Caucus, our tri-caucus, to achieve these goals. You all have been awesome. Thank you again for inviting me today, and please stay healthy.
Thank you for your remarks and for your allyship, Congresswoman Lee. It's now my pleasure to hand the floor over to Representative Ami Bera, who also co-chairs KPAC's Health Task Force. He represents California's 7th Congressional District. Before coming to Congress, Representative Bera was a practicing physician confronting the health disparities facing the AANHPI community every day. We're grateful to have his perspective here today. Please welcome Congressman Ami Bera.
Hi, this is Congressman Ami Bera. I want to thank AAPIs for allowing me to make a few statements at this second annual AAPIs Health Summit. It's important for us to understand the healthcare priorities and challenges that the Asian American, Native Hawaiian, and Pacific Island communities face, especially as we come out of this pandemic. The last 2 years have been incredibly hard on not just the United States, but the world in general. It's challenged us in different ways. And it's also exposed inequities in access to healthcare that we knew were there, but it's amplified that. So as we start to come out of this pandemic and think about how we as members of Congress, but also as a country, start addressing issues of access, equity, and fairness, we have to think about all communities. With regards to the AAPI community, we should think about making sure everyone has equitable access to broadband. We've seen the importance of telehealth, telemedicine. That is not going to go away, but if you don't have access to those broadband issues, then you don't have access to telehealth, telemedicine. We've also seen the increase in anti-AAPI violence and prejudice that's come about because of the pandemic. That's been amplified, and that's created mental health and community health challenges on our community. We've got to address those at a macro level, but we've also got to understand the root cause issues, especially as you see some members of Congress use very heated rhetoric when they talk about the Indo-Pacific or the People's Republic of China. That can inflame prejudices and racial animus here in the United States, which then leads to mental health challenges. And then on the more traditional side, with the pandemic, many people have avoided getting routine healthcare, whether that's for heart disease, whether that's for cancer screening, whether that's routine childhood immunizations. As we come out of this pandemic, we all have to work together to make sure we get back to a healthy community and a healthy country. That means going out there, bringing people back into the healthcare sector. This has been a challenging 2 years for us, but it does give us an opportunity to address issues of equity, of access, of quality of care for the Asian American, Native Hawaiian, and Pacific Island communities. Let's all work together to create a more prosperous, peaceful, and equitable future for the United States and the world. Be safe, be well, and let's be together. Bye.
Thank you for all of your service, Congressman Bera. Finally, before we jump into our first panel, one of our key sponsors for today's summit, Biogen, would like to share their insights.
The courage to strive for what seems out of reach. The resilience to learn from failure and keep moving forward. The hope that inspires us every step along the way. Deep within the biology of the brain is a set of intricate instructions that define who we are, how we move, how we think, our very sense of self. Sometimes these instructions fail. Our body becomes unable to read or respond to the signals, or something in the code itself goes wrong. When the errors reach deep into the brain, our complex neurology and natural defenses make repairing them all the more challenging. Neuroscience is the next frontier. The risk of failure keeps others away, but at Biogen, we are not afraid to go where others won't. Not because we can, but because we must. At Biogen, we are pioneering new science that takes us deep into the body's nervous system and stretches wide across digital networks and patient communities to better understand and preserve the underlying qualities of our essential human nature. Science that transforms patient lives by improving mobility, breathing, vision, and brain health. Science that seeks to solve societal problems and create access to innovation. Science that acts with purpose to address the urgent and long-term challenges facing humankind. Science that is inspired by the diversity and passion of our people. Courage, resilience, and hope. These are the qualities we seek to preserve. They are also the qualities that drive us to preserve them. Biogen, where science meets humanity.
Thanks to Biogen and our welcoming speakers for this year's Health Summit. I hope you enjoy the rest of the programming. Let's turn things over to Dr. Lena Wen and our first panel, Striving for Health Equity.
Good afternoon. My name is Dr. Lena Wen, Professor of Health Policy and Management at the George Washington University Milken Institute School of Public Health. Thank you to Madeline Milka and AAPIs for hosting this Health Summit. I am pleased to be here today to moderate our conversation entitled Striving for Health Equity. So I am really looking forward to this discussion with a diverse group of advocates, practitioners, and researchers. But first, we are going to hear from a strong advocate for health equity and for Asian American, Native Hawaiian, and Pacific Islander issues, Representative Judy Chu. Representative Chu.
Hello, I'm Congresswoman Judy Chu, Chair of the Congressional Asian Pacific American Caucus, or CAPAC, which represents and advocates on behalf of the Asian American and Pacific Islander community in Congress. Increasing health equity has been a long-standing priority of mine, and that is why I'm so glad that AAPIs, under the leadership of your incredible president, Madeline Milka, has put together this important and timely discussion. The AAPIs Health Summit is a tremendous opportunity to discuss often overlooked health issues and disparities in the AAPI community, whether that be higher rates of certain health conditions, healthcare access issues, language access issues, or the lack of available data on AAPI health. Without data on AAPI health, it's nearly impossible to understand the health issues that our communities are facing. We saw this play out during the initial months of the coronavirus pandemic, where AAPIs were listed as other on the CDC's website, robbing us of knowing COVID's true impact on AAPIs. That is why CAPAC members pushed for data disaggregation in the Affordable Care Act and have also asked the Biden administration to update data disaggregation standards for all federal agencies so we can better face challenges like the pandemic. In addition, there are startling health disparities facing AAPIs. For instance, although AAPIs make up just 6% of the total U.S. population, we account for over 50% of hepatitis B cases. AAPIs are similarly overrepresented amongst hepatitis C cases. Hepatitis B and C are the leading cause of liver cancer, responsible for over 65% of liver cancer cases. Liver cancer is one of the most lethal, expensive, and fastest growing cancers in America. And the rate of liver cancer in the U.S., as well as the rate of death from liver cancer, are rising rapidly. But the real tragedy is that these diseases are preventable and treatable. Hepatitis B has a safe and effective vaccine, and while hepatitis C has no vaccine, there are treatment options that can cure over 85% of cases. That's why I advocated for $134 million for the Center for Disease Control's Division of Viral Hepatitis in last year's congressional appropriations so we can address these issues. We must also ensure that our community receives all health benefits possible. For example, COFA citizens who are lawfully present non-citizens of the U.S. from the freely associated states of Micronesia and the Marshall Islands were mistakenly excluded from eligibility by the 1996 Welfare Reform Law. This meant that COFA citizens were not eligible for federal benefit programs, including Medicaid. In the years since, CAPAC has repeatedly pushed for a correction to be made to the law. Due to these efforts and the efforts of engaged community members such as yourselves, a provision that does exactly that was signed into law on December 27, 2020, as part of the COVID relief bill, allowing COFA citizens to finally obtain Medicaid. And now, since the start of the Biden administration, 197,000 uninsured AAPIs have gained access to health care. On top of this, AAPIs who have access to health care still face barriers in receiving culturally and linguistically appropriate care. For example, I was alarmed when I heard from the family of an AAPI woman who almost received a mastectomy on the wrong breast because of miscommunication between languages. Thankfully, her family caught the mistake in time and she was able to receive the proper procedure. But not everyone has family members who can readily translate for them in a medical setting. That is why measures that help us ensure that members of the AAPI community receive linguistically competent care are so important, and why I have advocated for the inclusion of language access requirements in the Health Equity and Accountability Act, or HEA, every Congress. HEA is a bill that takes a comprehensive look at ways to improve our entire health system to address minority health disparities. It's introduced every Congress by CAPAC, the Congressional Black Caucus, and the Congressional Hispanic Caucus, or what we call the Tri-Caucus, specifically to close racial and ethnic minority health disparities in all aspects of our healthcare system, from research to clinical trials to the way providers are reimbursed for care. It increases language access for AAPIs by requiring federal agencies to evaluate how well their programs serve individuals who have limited English proficiency, to translate all materials prepared for the general public, and to ensure that the healthcare programs they fund through grants and contracts provide meaningful language access. I thank the AAPI community, both locally and nationally, for all the work they've done to identify AAPI health disparities and advocate for policies that address them. Thank you, APACs, for inviting me to speak with you, and to all those joining today's esteemed panel. Conversations like these are critical as we work towards addressing AAPI health disparities, and I am proud to be a part of it.
Thank you, Representative Chu, for your inspiring remarks. I am now excited to introduce our 5 distinguished panelists. As I introduce you, could you please tell us more about yourself, your affiliation, and your organization's work in health equity? I'm going to begin with Lori Rubiner. Lori, welcome.
Thank you so much, Dr. Wen. I'm really pleased to be here. I'm the Executive Vice President at the Campaign for Tobacco-Free Kids, where we are working on reducing smoking rates, especially among organizations that are very heavily impacted, including minority groups. Thank you for having me.
Thank you, Lori. And we're also delighted to welcome Linda Murakami. Linda, will you introduce yourself and your affiliation?
Yes, thank you so much, Dr. Wen. It's so nice to be here. My name is Linda Murakami. I am the head of our global advocacy at Amgen. Amgen is a global biopharmaceutical company, and I lead our efforts specifically in prostate, breast, and bone health. Our organization does a lot in health equity, and it's one of the core pillars of our work. Thank you.
Thank you. And next we have Dr. Tanya Yi Vinton. Dr. Vinton, if you could introduce yourself, please.
Yes, hi, thank you. So I am a physician in Dallas, Texas. I'm double board certified in internal medicine and obesity medicine. I'm currently an assistant professor at the University of Texas Southwestern and also the medical director for our weight wellness clinic at Texas Presbyterian. I also started a nonprofit organization in 2019 called the Dallas Obesity Society that is dedicated to educating clinicians in the DFW area on the disease of obesity and also metabolic diseases that are related to excess fat.
Thank you, Dr. Vinton. Our next panelist is Dr. Mahesh Krishnan. Dr. Krishnan.
Thank you. Mahesh Krishnan, one of the DaVita Chief Medical Officers, oversee research and development as well as healthcare policy in DC. DaVita is one of the world's largest renal organizations, and one of the issues that we are really working on relative to health equity is improving outcomes for patients across the board, specifically in renal disease, both in terms of the detection as well as treatment of renal disease.
Thank you, Dr. Krishnan. And finally, last but certainly not least, we have Sherry Daniels as our final panelist today.
Good morning, Velina Mai, everyone. Thank you, Dr. Wynn, and Apex for inviting me here. My name is Sherry Daniels. I'm the Chief Executive Officer of Papaola Lokahi, which is the Native Hawaiian Health Board. And our kuleana, our responsibility, is for the health and well-being of Native Hawaiians, both in Hawaii as well as across the United States. And so I'm really excited to join all the other wonderful panelists today. Thank you.
Thank you so much. And I think you can see, based on the introductions of our panelists, that we have such a diverse group. And I am really delighted to be moderating this conversation. So I want to begin with a discussion on the existing challenges and barriers within the Asian American, Native Hawaiian, Pacific Islander community. And perhaps if I could begin with you, Sherry, to lay the groundwork and talk about what are some of the systemic challenges to addressing health equity within this community.
Thank you. And I think we all are very familiar as we've watched the news over the last year, especially, but as we've seen the impacts that systemic racism has had on our communities in our Asian American, our Native Hawaiian, as well as our Pacific Islander. And, I think we've all recognized the need for equity, inclusion. Diversity is not a new thing. Our communities have been diverse for generations, but I think we've come to recognize, and that issue has been highlighted over the last 2 years, especially around what that means to have diversity, what it means to have equity. I think we often forget that when we get invited to spaces, right, we're wanting to help the other communities have a voice, not be forgotten. But oftentimes that's also not providing equity, that we need to ask, where are those other communities so that we can have a broader collective, collaborative voice when we talk about health equity. I think systemically, we often are in systems, resource holders, policymakers, funders, where the belief is that they're helping our communities uplift. And I think often we forget that communities do have a voice, they have a narrative, and equity means bringing those voices together, even if maybe it doesn't move the process along in the way we want it to. So I think it's being very thoughtful and intentional in how we develop equity, and that and today we're going to hear there's so many threads of equity and what that looks like, and how do we tackle these different threads in a very thoughtful manner so that we don't leave people behind, or that communities, whether it's geographical, whether it's race, ethnicity, aren't left behind. And I believe it's those kinds of conversations that we need to have, and we're going to have today. So thank you.
Well, I appreciate that. And it's hard to talk about equity, of course, without discussing what kinds of barriers might exist. And so here I want to turn to Linda Murakami. If you could give us just the lay of the land when it comes to the types of economic, cultural, linguistic barriers that might be unique or present, at least in the Asian American, Native Hawaiian, Pacific Islander community.
Absolutely. I guess I can best capture it by there are many different barriers. As you mentioned, there can often be cultural and linguistic barriers. Our community is so diverse, not just from a racial ethnic perspective, but you also have folks who may be new generational here. You may have the specifics about how people access care, and if they do. Within our community, oftentimes you need to have solutions that are crafted at the very local level. For me, I'm a recovering policy wonk, and so I always think policy is a really important component, and oftentimes you do not see the AANHPI community specifically represented in policies that can increase the access to healthcare, and that they know exists for them. It's one thing to have a policy that is broadly inclusive, but if the community is not intimately aware of how to access and how to utilize it, you can have many challenges. You also have fear, honestly, in many communities about different parts of healthcare. I think about clinical trials and the importance of having diverse populations represented. Oftentimes, for my work, I think about communities that have an overrepresentation of certain health issues. I think about bone health. I think about things like gastric cancer. We think about liver cancer, things that overrepresent. So for us, when we think about those disparities, access to health and those barriers, for us, it's really thinking about how you work with the community, how you work with trusted leaders within the community and folks where our diverse populations really go to seek that guidance.
No, I appreciate that. And I really appreciate your discussion of how you could have the best service available in the world, but if there are barriers to that access, that's not really reaching the populations that it's meant to serve. Dr. Krishnan, I know you had mentioned your work with DaVita. Could you also add to this conversation when it comes to additional barriers that you might see, and what are perhaps some strategies to help to overcome these barriers?
Sure. So I think for any healthcare interaction, it is very personal, right? It's a decision between the patient and the physician. It's a decision between the patient and their family. And a one-size-fits-all approach is not going to work for that. And so as we think about some of the barriers that you mentioned, socioeconomics, cultural, linguistic, it's really important to address that context. So if we're talking to patients, for example, to advocate for a transplant or to advocate for a home dialysis or even to get on dialysis, to think about hospice care, any of those aspects, it's really important to get the cultural context correct. And so how we do that at scale is quite interesting. We have 3,500 clinics across the United States. And so we serve a lot of different communities, but we have to actually serve the individuals within those communities. And so tailoring our communications practices, whether that's with our teammates or whether that's digital, trying to really understand some of the linguistic issues and offering a wide variety of languages in a lot of the education materials and conversations is quite important. And then addressing the socioeconomic areas and health equity related issues of health literacy, food insecurity, housing insecurity, all those are quite important because we have to treat the patient holistically. It's not just about the dialysis care, their renal care, it's about them as an individual.
Thank you very much for that. Now, Linda had mentioned about some of the diseases that may be more prevalent within the AANHPI community. I want to turn to Dr. Vinton to talk about this in a bit more detail, about other diseases that may be more prevalent that perhaps people are not necessarily aware of. And I certainly would love to hear more about your approach to working on obesity as a disease, and nutrition issues also within this community.
Great, thank you so much. So I'll start off with some statistics. So Asian Americans are actually 40% more likely to be diagnosed with diabetes compared to non-Hispanic whites. Asian Americans are also 60% more likely to be diagnosed with end-stage renal disease compared to non-Hispanic whites. And then also very shocking, I would say, is that there's actually quite a bit of non-alcoholic fatty liver disease in Asian Americans. Now, this is probably one of our most important chronic liver diseases that are leading to liver transplantation nowadays. And again, a lot of this is going unscreened and underdiagnosed in Asian Americans because our usual cutoffs, or when we start to screen for these metabolic diseases, starts around a body mass index of 25, that's your overweight, up to the obese category of up to 30. But in Asian Americans, these BMI cutoffs are really not appropriate because actually many of these diseases start at BMI of 23 or even lower. So this is why we're not capturing these patients until they're really quite advanced in their disease. So despite, they may have access to care or whatnot, they're simply not being screened. There's a lack of awareness from Asian Americans in general, and then also their clinicians are not really attuned to screening for these diseases at an early stage.
That's fascinating, and I think that's such an important point about the level of individualization that also has to occur, right? That it's not one size fits all, and being aware also of the needs in different communities helps to drive that. Now, I know, Lori, you are well recognized as a fantastic advocate, and I wonder if you can shed some light on approaches to advocacy on behalf of the AANHPI community, and any lessons that you might have for those who are part of this conversation today.
Well, I thank you, Dr. Wen, and I want to pick up on that one size doesn't fit all, especially in the Asian American community. Cancer, as you know well, is one of the leading causes of death in the United States, and that's not lost on the Asian American community either. There's more than 19,000 Asian American Pacific Islanders who are diagnosed with a tobacco-related cancer each year, and then more than 9,000 die from a tobacco-related cancer each year. Now, the good news is that Asian Americans have some of the lowest smoking rates of all major American racial ethnic groups, lower than the average, lower than most Americans. But there are distinct differences in smoking rates among subgroups. And the tobacco companies have taken advantage of that. And so one thing that we, with targeted advertising and pernicious marketing, and one thing that we have learned as advocates is it's very important to be reflective of the needs and thoughts of the communities that we are trying to serve. And of course, we can't compete with the tobacco industry and the money that we spend, but we can showcase our broad and diverse coalition of individuals and organizations that are trying to eliminate tobacco-related health disparities. And it's very important that we listen to the community and elevate voices from those communities and make sure that we understand that there are very big differences in the Asian community in smoking rates. And it's not one size fits all. And we have to listen very carefully and make sure that we understand that the Vietnamese community has different smoking rates than the Korean community, than the Chinese community, and target our advocacy in that way. And to borrow from Appeal, which is one of the big advocacy communities in the Asian American community, one thing that they say is eliminating tobacco use and achieving health equity in the Asian American community is not a one size fits all approach. We know that it varies, and we have to tailor our advocacy appropriately.
I want to pick up on that too, and actually turn to all of our panelists to talk about this question about how your organizations or the people that you work with are tackling these barriers to health equity. Beginning, let me come back to Sherry for your thoughts on this about the work that you're doing and lessons that you might have for others.
Thank you. Everybody's touched on a lot of things that are common threads. I think we're talking about social determinants of health, which we're also in some ways trying to figure out how we deal with some of the shifting in landscapes in terms of we recognize the need for customization for really looking at communities and individuals, but not everybody has looked in that way. We've had to deal with blanketed approaches to care, to the delivery of services. So I think when we look at how we need to move forward, especially for the NH communities, for the Native Hawaiians, when we're talking about access and linguistics, for us, it's almost the reverse, that our community is bilingual. English is often the first language, but many of our communities also speak Olelo Hawaii. And that's not allowed in terms of accessing care, right? It's not limited. So I think even the words we use around limited language access, it should just be there's a language access need, whether it's you need English or let's support them in the language that they're comfortable with. So I think those kinds of, even the words we use now, how do we really look at that and have it be adjusted to what we want our communities to thrive around? I also, Dr. Vinton talked about cutoffs. I mean, the other thing to look at is life expectancy rates. I think for Native Hawaiians, our life expectancy rate is still lower than the average of the national average, even in our AAPI community. So really looking at, I think it's hard sometimes to advocate strongly or talk about some of these changes because we're very committed to the communities in which we serve. And every community is different, whether they're in Hawaii, in California, in Wisconsin, in Tennessee. And so how do we be better in advocating and customizing that in the general? So thank you.
I appreciate that. Thank you very much, Sherry. And Linda, you had mentioned a little bit about this when it comes to recruiting people in clinical trials, but would love to hear more about how you're tackling barriers to health equity in your work at Amgen.
Absolutely. Thank you for that question. So getting to the policy issue, one of the areas where we are investing in a sustained manner, and for us, that's really important, not to kind of have this spike up and then down. We find consistency and transparency in supporting groups and relationships is really important. So our relationship with groups like APACs, and certainly the Asian Caucus, that includes Native Hawaiians at the state legislative level, is very important. We work closely with them to support the work that they're doing. Again, they reach back into their communities so that it is fully appropriate and representative. From a peer advocacy perspective, we take the same approach. It's really going into communities that are creating for themselves the program so that it can be tailored and of the community. For us, we find it shouldn't be top down. It has to be anchored in the community. And Sherry, when I hear you speak, I think that is critically important, certainly for the Native Hawaiian population. It can be in language, right, delivered appropriately by the community members. For us, it really is that very important, anchored to community, bringing resources in as asked, providing, examples of best practices, but it cannot be kind of a one-size-fits-all and in a very aggressive manner. What we find is that leads to success. On the early development and on the clinical trial perspective, we're taking a very intentional approach to reaching out again at the community level and trying to partner up kind of community health center, community hospitals, and then bringing in and connecting to the centers of excellence. What we find, especially in oncology, is you have a majority of patients who are served at the community level. And so doing what we can to strengthen those connections is very important.
Thank you for that. And let me turn to Dr. Krishnan, too, to talk about some of the work that you and Davida are doing in health equity.
Yeah, back to the one size doesn't fit all. We've really taken a service design approach to how to deliver care at an individual level. So those of you that might not be familiar, service design is basically the concept that you can design a service process the same way you design a product, right? So it's reproducible and consistent. And that's complicated because we want it to be reproducible and consistent at domestic scale, but we also want it to be personalized, right? So in a way, we want mass customization. And so the ways that we've actually approached that is really to, number one, meet the patients where they are. So we have social workers and dietitians, for example, that are in the communities that they serve. And so they can modify and customize everything they need to do. So in Sherry's case, we might have a dietitian in Hawaii that might be advocating for something very different as it relates to diet, as opposed to someone that's in Connecticut, for example. In addition to that, we've also strived to sort of figure out how to address the educational issues. So as we've thought through how to do this, there's two different aspects of how you would identify the personality, the Match.com profile, if you will, for the individual patient, to really customize it for that individual person. On the one, it's the things that we've talked about. It's language preference, it's cultural context. There's a lot of specificity there. And we've looked at that both from an operational perspective as well as from an investment perspective. We've made an investment in a company called Consejo Sano, now WellSky, which tries to do culturally appropriate communications for folks. The other aspect of that is really in terms of the interaction and the educational efforts and how we actually customize those. And so that can take the form of digital, that can take the form of other areas. And the way that we try to do some of those things is also by the use of Z codes. So the ICD-10 Z codes, which actually describe some of the things we've been talking about, the social determinants of health, access to food, housing insecurity, food insecurity, health literacy. We're trying to figure out how we can get those coded in our systems. Those are in the ICD-10 code set, but aren't very well used today. And we think the combination of those things, the individual Match.com profile of all the patient level preferences, plus some of the Z codes, might actually allow us to provide that mass customization and consistently deliver a personalized interaction with our patients at domestic scale.
That's a very helpful context. Thank you. And Dr. Vinton, how about the work that you're doing for addressing health equity, whether it's with the disease of obesity or on other issues?
So let's say most of our patients, our Asian American patients, especially when they come in to see me for improving their health, decreasing weight, I think one of their first concerns is, you're going to make me eat that diet that is really popular right now, like keto or Mediterranean diet. And obviously this is not palatable for most Asian Americans. It's very, very different from what they're culturally accustomed to. So it's very important, I think, when we talk about making lifestyle modifications, especially in this community, that we are very sensitive to that. And we make adjustments with them with dietary preferences that are conducive to good health and they're sustainable. So for example, simply by decreasing some of the processed carbs in the diet, that's very, very helpful. Time restricted eating, in the sense of doing kind of our smaller windows of eating, 16 hours of fasting, 8 hours of eating windows, can actually be very helpful in metabolic health, where we don't actually have to necessarily change a lot of the things that you're eating, but just by making some alterations, that can very much be extremely helpful in both decreasing weight, excess fat, and improving, say, like risk for diabetes and heart disease, stroke disease. So a lot of this we do advocate through our Dallas Obesity Society educational programs for our clinicians, because I think traditionally when clinicians are trying to offer what they think is good health advice, becomes very, very blanketed. You know, if you want to lose weight, you go to Weight Watchers. If you want to do this, you go try the keto diet, or you do Jenny Craig. But it really needs to be much more of a personalized discussion with the patient in order for it to be ultimately sustainable and successful.
I also, in addition to this being personalized, I also like what you said about the specific example of making the time limitation, as opposed to telling people, here are all the things you can't do, which may be very difficult for many people to abide by. So thank you for that. Now, we have heard a lot about the wide range of efforts to tackle this issue of disparities and aiming for health equity. Of course, it's important for us to drive towards solutions and results. And so I am curious to hear from all of you on how you define success. And examples also, if you want to present any, to lift up any examples from communities or from your work or any other work. Just, I think, so often we hear of the problems, and we have already laid out what the problems are, but laying out what success means and examples of success can also be inspiring for progress in a different way. And so I'd like to begin with Lori, if I may, with that question.
Thank you. I mean, we've made some great strides in the tobacco control movement. You don't go into a restaurant now where people are smoking. You don't sit on an airplane and have to sit in a smoking section anymore. Those are things that we take for granted now, but those were very hard fought battles. And we've cut the smoking rate almost in half since the Surgeon General declared many years ago that there was a huge problem with smoking. But unfortunately, tobacco use has become more and more concentrated among certain population groups, and it really has become a targeted marketing effort for lower income groups, those of lower socioeconomic status, certain racial minority groups and ethnic groups in certain geographic regions of the country. And that's where the health disparities come in because the tobacco companies know that they still need customers. And so they target those who are less fortunate with their products. And so we have been working very hard to try to find ways to protect and help those individuals who are still the target of the tobacco companies. One of the most impactful things that we still have left on our plate is to prohibit flavored tobacco products, especially menthol cigarettes. Menthol cigarettes are a tremendous public health threat. They are targeted to mostly the African American population, but also 31% of Asian Americans smoke menthol cigarettes. And the reason is that menthol masks the harsh taste of tobacco, and so it's much more, people become much more easily addicted to menthol cigarettes. We are working to prohibit all flavored tobacco products, but we're also working right now. We've got an effort before the FDA to ban all menthol cigarettes, which would be a tremendous step forward in health disparities. So we're very hopeful that will happen this year with this FDA.
Thank you for that. And I'm, again, thank you for that very specific examples. I think a lot of us will remember the days when indoor smoking was the norm.
Yeah.
But now it seems like such a long time ago that in a way we almost forgot the difficult battles that got us to where we are. So I think that's a very powerful, specific example. So appreciate that, Lori. And how about you, Linda? How would you define success, and what are some examples that you may want to lift up?
Absolutely. So for us, I think we would define success really looking in the policy arena. Groups like AAPIs, the Tri-Caucus, at the state level, the Asian American growth, the number, the representation. I feel like that for us is a true nod to more policymakers being represented at the federal and state level, and then you will then see policies coming to light. I think for us, one of the things that we always want to make sure is that, as opposed to a separate afterthought, being really in the mainstream and making sure that our voices are integrated is really important. First, the patient journey and the patient voice really shows up in how we support at the community level the various AANHPI advocacy organizations. And for us, it's the growth in the number of organizations that exist. It's really one of those kind of a resourcing issue, it's capacity building. It's really kind of that learning from one another. And what Barry mentioned, it's making sure that voices are at the table. Instead of assuming that the table is a certain size, it's really saying, we're here, why are there not more voices? Within Amgen, our focus is really to bring that external perspective inside. And so when we look at disease areas that do overrepresent in this community, that is like a natural part of the conversation, from research through clinical development, commercialization, and beyond. So for us, it's really wanting to make sure that we're seeing kind of growth in policies, policymakers, advocacy groups, advocates, and then at the end of the day, it's really access and seeing increased health outcomes for patients.
Thank you so much for that, Linda. Dr. Krishnan, I turn to you for your thoughts.
Yeah, I think one of the speakers actually teed this up already, but renal disease is unfortunately a health equity issue in and of itself. If you look at the prevalence of renal disease, if you look at the progression of renal disease, you see areas where either by race or other areas there's imbalances. And so the renal community has actually made great strides to try to reduce those over time, but we are far from perfect, but we're also far from done. So the objective markers that what you could look at in terms of renal disease is the percentage of patients who progress from chronic kidney disease into dialysis, right? You'd like to see that slow down either by racial type or by Z code for SDOH factors. The percentage of patients who go on from dialysis and crash into dialysis, right? Unfortunately, in the United States, 50% of patients don't actually know they have renal disease. They show up in the emergency room for some other reason, and they're told, oh my goodness, you have end-stage renal disease, you need dialysis. So we'd like to slow that down by racial type as well as by Z code. And then lastly, the two real important metrics are the percentage of patients who are on home dialysis, which could be a better modality for some patients as opposed to going to the dialysis clinic 3 times a week, and the patients that receive a transplant, right? I think that's another aspect of a whole integrated system of how you educate patients, how you match donors. There's a lot there. So those are the 4 big metrics: percentage progression, percentage that crash into dialysis, percentage on home dialysis, and percentage on transplant. And then you'd want to see improvement of that over time by racial subgroup or by Z code.
Very helpful to hear the specific metrics as in a very explicit way, which is very helpful. Thank you, Dr. Krishnan. Dr. Vinton, metrics of success and how and anything you want to say on this topic.
So I think part of what's most important in my interactions with Asian American patients is that there's really definitely a lack of self-awareness about the potential burden of disease. So I would hope that more just community programs are out there to elevate awareness. From there, what I work with in our community, our Dallas Obesity Society, is educating clinicians at that level to understand, to do screening, to talk about prediabetes, diabetes, heart disease, stroke disease, kidney disease, even increased risk of cancers that are related to excess fat, but again, at lower BMI ranges for Asian Americans. I guess one of the good things about talking in the obesity space is that people are very, very much interested in listening at this point. It's estimated in 2030, over 50% of Americans will be obese. So there's a lot of clinicians coming to the table talking about obesity. And I think that's one of the perfect ways for us to elevate awareness of metabolic disease in Asian Americans and how the BMI ranges are very, very different and much lower in our Asian American Pacific Islander groups. So that's what we're doing here in Dallas, and I hope other areas across the U.S. Also take on this effort.
Thank you, Dr. Vinton. And turning to Sherry for your thoughts about defining success.
I think success, it's all captured right here. I think there's the hard numbers, right? The reduction of obesity or chronic diseases. But I think there's also the soft factors, which is community and really seeing from them what success means to them. And did we hit their benchmark? I do think success also is then taking it kind of from a higher vantage point and seeing where the bridging happens. And I mean bridging when we have communities and policymakers, resource holders being able to come to the middle of the spectrum to have conversations and build capacities together. So that bridging, I think, is also a factor of success. Trust is a huge factor of success, that we can talk all we want about how we cross, pollinate with each other and have conversations and collaborate and partner, but really, is there trust so that those factors can be sustained? I think that's the big piece around success for Native Hawaiians is, one, do we trust you? Can we trust you? And trust for us means a long-standing relationship. And so even for Pacific Islander communities. And then finally, I think when you're not able to have space at a table, I do recognize now another factor of success is for our NHNPIs that we're able to go and build our tables, that we're able to go and create tables so that our voices and our narratives are clear, because that's important for us, right? And we see that in many communities where there are those tables being built and have been built for a long time. And I think for success for NHs and for PIs is that we're okay and comfortable that we can build our own tables, that culturally we often aren't. We're often a little bit more like, no, it's okay. We're not going to ask for more than what we need. But now I think success also is measured by our ability to build our own tables. So yeah, I think success is very multi-pronged. Thank you.
That's wonderful. Thank you for that. Now I'm going to do a speed round, if I may, to ask everyone in the same order that I initially introduced everyone, to give us one thing that you would want to take away as we conclude, and one thing that you would want for people to take away to move us forward. So beginning with Lori, if I may.
The importance of partnerships. We have a very broad, diverse coalition that is working on tobacco control. It includes doctors, cancer researchers, dentists, women's groups, civil rights groups. And I think the broad diversity of that group has really helped to push our issue forward.
Thank you. Linda?
Yes, I would jump off of that and say collaboration and partnership, really viewing the biopharmaceutical industry as a partner, bringing therapies and wanting to do good work at the community level and be very representative. So collaboration.
Thank you. Dr. Krishnan?
Yeah, I think in order to improve renal care in general, it really requires a bottoms-up approach. It really requires listening to the patient, listening to the providers, listening to the community. You can't just come up with a top-down approach where you decide what it's going to be. In order to really customize and personalize, you really have to listen and learn and be humble, and then design programs that are able to be adaptive to meet the patients where they are.
Thank you. And Dr. Vinton?
Preventative care is extremely important. The earlier that you detect a disease, the earlier that you can do something about it. And definitely long-term lifestyle changes, diet changes are sustainable, they're doable, and better yet, they can actually reverse a lot of these very chronic, very devastating metabolic diseases that are afflicting us.
Thank you. And Sherry?
I would think communication, which touches upon everything everybody on the panel has talked about, but communication, whether it's developing relationships with communities, policymakers, and I think communication in terms of having hard conversations or uncomfortable conversations that might need to happen to help our communities find success.
Thank you all so much. Now, I hope that everyone who's listening and watching have gotten a lot out of this conversation, as I have. My summary of our wide-ranging discussion is that we have to think and do a lot more about health equity. Certainly, we have to do a lot more when it comes to the AANHPI community, and consider barriers and talk about how availability of a service alone is not enough. We have to have the right people at the table, not making assumptions about what people should be doing. As has been emphasized by all of you, the engagement, building relationships, developing that trust, engaging in partnerships and collaborations, all of that is so crucial. Also, we had a broad conversation about how this is not one size fits all, that when it comes to whether it's clinical care or public health, that at the end of the day, this needs to be personalized, that the recommendations need to meet people where they are, which actually is a core principle for us in public health too. I'm glad that we spent a lot of time focusing on successes and how we define successes, and that it's a combination. It's a combination of metrics that we can measure specifically, but as our panelists discussed too, there's a lot more that's there. Prevention, for example, is something that often is hard to measure and yet is incredibly crucial. So is community engagement or building that trust. And so I think as we celebrate the great work that's been done, there is a lot more looking forward that we do still need to aim for. And so I hope that this has been a fruitful conversation for all. I want to thank Lori Rubiner, Linda Murakami, Dr. Tonya Yen Vinton, Dr. Mahesh Krishnan, Sherry Daniels for your insightful comments and inspiring remarks today. And I also want to thank Apex for convening this panel. Thank you all very much.
Thank you.
Thank you.
Thank you.